For the viewers out there, if you have questions, you can raise your hand and we will turn the microphone over to you, or you can stick a question into the Q&A chat function. I do have one question along those in the Q&A chat for Dr. Brawley. It was from your presentation, can we get these numbers by state? This is a reporter, Lucia Walinchis from Ion, Ohio. She's interested in Ohio numbers. I think when she was asking about the when you were doing the deaths, the death numbers by disease nationwide, are those things available by state?
Yes, the death rates, the actual numbers of people dying of various diseases by state are published by the U.S. Centers for Disease Control.
Okay.
Yeah, actually, it's very easy to get it off of their website.
I do have a question from Nancy Prager Kamel, chair of the board of the Association of Foreign Correspondents in the USA. Disparity in income has become exponentially increased with little hope of arresting this degradation. What possible solutions can be found? Could the desperate need for the US to invest in infrastructure rebuilding be an answer? So this is a look at disparity in income. I mean, do either of you have thoughts on how that can be reined in?
I will not answer that question, as I think it's more of a political issue. I will tell you that U.S. disparity in income has increased every year since 1980. And many of our problems are related to disparities in income. But how to overcome that, that's for someone not in my pay grade.
Okay.
Well, I've been, I think it's called Summer Holiday. During my summer holiday, I've been reading Piketty's second volume, Capital and Ideology. His first one was 860 pages, and it was such a success that his second one is 1,042 pages. And I'm halfway through and I'm exhausted. But he makes the point that I showed you some slides on tax rates, but he makes the point about pre-distribution. In other words, the way of reducing income inequality is not only through the tax system, but he makes a good case based on evidence that the higher marginal taxes on rich people did not reduce productivity, as rich people like to claim, but it did have a role in reducing the pay of rich people. If you're paying so much of your extra income in tax, why pay? Why get bigger income? And in fact, it was the reduction in that top marginal rate that I showed you that was one of the drivers of the increase in so-called compensation, I say so-called, for people at the top. And that runaway increase in income, and it's not just between top and bottom, it's between the top and the middle. It's a runaway for the top 1% and the top 0.1%. So one's got to pay attention both to what happens to primary income before the tax and benefit system, as well as the taxation system. And it doesn't have to be the way it is in the United States. In many European countries, there has not been that runaway increase in inequality. And the argument put by the rich is we need that inequality to guarantee the productivity of the economy is wrong. It's incorrect. It's false. It's self-serving nonsense. Because if you look at European countries that haven't had that same runaway growth, their productivity is equal to that of the United States. So it's not necessary to have those huge inequalities in income. They are self-serving for a tiny minority of the population.
Okay. So we have a question, an audio question from Gracie Todd, who is the Howard Center Fellow for Investigative Journalism at the University of Maryland. Tyler, if you can unmute Gracie and you can ask your question now.
Hi. First, thank you both so much. That was a really great wealth of information and a lot of ideas for different statistics and issues to look into when reporting on this topic. So thank you. My question is, how might experiences of stress or trauma disproportionately affect the health of people living in poverty? And is there risk that the COVID-19 pandemic may be especially increasing stress among those living in poverty and then compounding those health problems related to trauma?
Well, if I may, very much so, very much so. When I said at the start that the pandemic exposes and amplifies the underlying inequalities, Dr. Brolly made this clear in his talk as well, that lockdown and the steps taken to deal with the pandemic have increased inequalities. Exactly as Dr. Brolly said about the United States, we see in Britain. We know the ability to work from home is closely related to status and income, that people in high status jobs are more able to work from home. People in low status jobs are less able to work from home. They lost their jobs or they were forced to be exposed. We did a report on bus drivers in London. Bus drivers have something like 3 times the mortality from COVID-19 compared with other people of working age because they're out exposed, or people lost their jobs. Now, I showed you 2 million children in England were food insecure. If that doesn't cause stress to the parents, let alone to the children, nothing would. What could be more stressful than inability to feed your children because of lack of money? And we already have signs of increases in mental illness, alcohol consumption going up, increases in calls for relief of domestic violence. There are a whole set of indicators that are looking adverse at the moment in terms of mental illness, and it's highly likely, but we don't have it yet, of stress-related physical illness.
If I could just add, the opioid epidemic that we've had in the United States is resurging again, and we're having increasing numbers of deaths from illegal use of opioids, number one. Number two, being a clinician, let me tell you, some of the people who get this disease have just a horrible disease where they have shortness of breath, they have pains, they have a number of symptoms. And that leads us to concern that once they get over the disease, if they do survive, they're going to have a post-traumatic stress disorder. And so there's a PTSD of individuals who really suffered from the disease. Then there's a PTSD from people who are trying to avoid the disease. So there's going to be a number of long-term negative outcomes related to this disease. And the last thing I'll point out is in history, just a little history. We had the Spanish flu in the late 1918, 1919 era. It was in the 1940s and 1950s that we were still finding certain things that occurred in the population that were related to the Spanish flu. For example, people who got the Spanish flu had a higher incidence of Parkinson's disease in later life. I don't know what the long-term effects of this will be, both emotionally and physically.
Okay, so we have a question here from Nima, the reporter from Bhutan. It's for Sir Michael. If you could briefly explain how it happens that policy makes people poor. I've heard about the same message said in other ways, where it is said that the rich pay less tax compared to those in poverty. Can you suggest some policies you have observed in developing nations that might help alleviate this?
It's a challenging question and a good question. I've asked myself, take the UK first, then I'll come to developing countries. I've asked myself, why would the government pursue policies that predictably made poor people poorer? Well, I don't know what government ministers tell each other or tell themselves when they're in the quietude of their study late at night. Do they say, I did a good job today? I pursued policies that made poor people poorer. Wow, what a clever boy am I? Do they say that? My guess is they tell themselves, we had to take difficult decisions to put the economy on the right footing. And if we get a good economy, that'll benefit everybody. That was economically illiterate. It turned out to be quite wrong as a way forward. And many people told them that it was wrong, but it fitted with their ideology and was convenient. Whether there were, and I'm being kind in saying that they were simply economically illiterate. They weren't actually mean and nasty and uncaring, which is another hypothesis. But I would never suggest such a thing. So I'm being kind. So then the question is, how do we bring it to the attention that government policies are harming people? Now, there are some politicians, some probably not very far away from where some of you are sitting, who are impervious to evidence. So you couldn't bring evidence to their attention because they don't have receptors to receive evidence. But some politicians are normal people and they can receive evidence. And I'd like to think that if we bring the evidence to people, it will make a difference to the way they think. They might still say, my model says, let's grow the economy, and by setting rich people free, we'll grow the economy, and that'll benefit everyone, trickle-down economics. The fact that trickle-down economics has been proved not to work doesn't stop some people believing in it. So then the second half of the question is, well, do we have models from developing countries? I've just written a paper with the vice president of Costa Rica. And Costa Rica famously, I don't think of it as a developing country, but the vice president describes it as a developing country. Costa Rica famously, if you look at the United Nations Development Program, UNDP, Costa Rica is actually high human development, not very high. There are 52 countries that are very high human development. Costa Rica's life expectancy at 80, that's men and women combined, puts it in the middle of the range of the very high development countries, higher than the United States. If you look at its income, it's much lower national income than that of the very high development countries. National income adjusting for purchasing power is about $14,000 a head. In the United States, it's $60,000 per capita. So at a fraction of the national income, Costa Rica has longer life expectancy than the United States. So then the question is, what did it do? In the new constitution of Costa Rica in 1949, it abolished the military. Get rid of it. No spending on the military, no armed services. They said, why do countries spend on the military? Well, most countries in the Americas have the military to suppress their own citizens. Costa Rica decided to invest in education, in healthcare, in social development. Back in 1949, they started to develop universal health coverage and education and clean water for everybody. Now, they still have big economic inequalities. It's not miraculous. They didn't achieve equity of income. They still have big income inequalities. But a large part of national expenditure goes into improving the well-being of the population. So it's quite possible for countries at relatively low income to make these political, social decisions that invest in the well-being of their population. And the evidence is right there for Costa Rica. Life expectancy in the middle of the range for the very high development countries, higher than in the US.
Okay. So another question from Lucia in Ion, Ohio. This is for Dr. Brawley. Where do you think the best data, where is the best data to get on how poverty affects respiratory diseases? We know that living among high pollution areas leads to more asthma and more COVID problems, but it's hard to find causal connections. So any suggestions on where this reporter can find data on respiratory diseases?
I'm struggling on that one. First place I would look would be, again, the Centers for Disease Control. They've had a lot of criticism lately, but seriously, their website has wonderful, wonderful data. The National Institutes of Health, less so on policy and less so on terms of population, but may have some data specifically on pollution and what it causes and what the likelihood of someone is to develop, for example, COPD from years of exposure to pollution and that sort of thing.
May I add that
Sure,
there
yeah.
is a pretty strong evidence base in the United States for this, and there's similarly in the UK. I think there are good causal connections being established between pollution and chronic obstructive pulmonary disease. Look at mortality data. There have been specific studies like the Harvard 6-city study, but there's been Los Angeles for obvious reasons. There's a good evidence base for this.
Okay. So another question addressed to Dr. Brawley, but I think both of you can probably touch base on it. This is from Thomas Barat, who is editor-in-chief of CCO magazine. In your opinion, the second wave started in July. How long is it expected to last? And can it be said that the main reason is non-compliance with social distancing or looser interpretations of regulations, holding events, opening restaurants, and starting schools and so forth?
I don't know if the second wave actually started in July. I don't know if the first wave has actually ever ended. I would agree with the statement or the implied statement that social distancing, wearing of masks would decrease this pandemic or decrease the effects of this pandemic significantly. I think the closing down of the United States, if we'd been able to do it well, would have also decreased the effects of the pandemic. Right now, I think that masks and distancing is still an important thing to do to try to minimize any waves that are out there.
Could I add something to it? Can I have your permission to share my screen?
Yes, please do.
Show you a slide?
Yes.
Oh God, if it works.
Okay, it's up there.
Good. Just last week, an organization publishes the Social Progress Index, and they have 16 indices. And I chose 2, and I plotted for 3 countries. Germany, which has controlled the pandemic very well, and the USA and Brazil, which have controlled the pandemic very badly. So look at the index of inclusiveness. Germany, it was trending up a little bit, down a little bit, up a little bit, more or less no change. The United States, the index on inclusiveness, I don't know what happened between 2016 and 2017. Maybe somebody could tell me what happened on the 20th of January, 2017.
I'll look it up in the old newspapers.
You could tell me afterwards. But inclusiveness went down. And in Brazil, that had their own version of what happened in the US, inclusiveness fell dramatically. Now, these two countries handled the pandemic very badly. Let's look at another index, personal safety. There's Germany, high and little change. My God, what did you do in the United States on the 20th of January 2017? But personal safety went down dramatically, and it trended down in Brazil. So these are indicators of social progress. I can't answer the question of when, I can't predict when it's going to go up and down and stop. But what's interesting is this is not even a correlation, let alone established causation. It's speculation. But countries that are doing poorly on social progress are doing poorly on handling the pandemic. And the UK is among them. As I said in my talk, we were doing very poorly in my report in February, and we've handled the pandemic very poorly. So trying to make a prediction is difficult, but it's reasonable to say that the countries that were not doing well on other indicators of social progress are not doing well on handling the pandemic. Given that, you wouldn't be very confident in making a prediction either in the UK or in the US, let alone Brazil.
If I can just bring this full circle, Germany is 1/5 the size of the United States, and it has had about 8,000 casualties, 8,000 deaths due to the coronavirus pandemic. At a time, that is to say, at a time when the United States has had 200,000 deaths. If we had been able to control the pandemic in the United States the way they controlled it in Germany, we would now be looking at less than 40,000 deaths instead of 200,000.
Okay. Well, Dr. Brawley, I was hoping you could maybe touch on the difference between urban and rural, between the poor in rural areas versus the poor in urban areas. And do they suffer equally from chronic diseases of poverty like hypertension and diabetes? And are they suffering equally from COVID, or are the social distancing norms in the two places different enough that they're not?
Yeah, there are some differences between rural and urban. Urban has tremendous problems in terms of social distancing that you don't see when we talk about rural. There are very slight differences in the United States in terms of the prevalence of hypertension, diabetes, when we look at rural poor versus urban poor. Poor is bad. Rural versus urban is not as much the driver of these diseases.
So let me ask this is kind of a speculative question here, but we know now that COVID has hit the poor much harder than others. Could that have been prevented from have been prevented from the start, or maybe how can we prevent it next time an odd virus pops up that we've never seen before? I mean, what are there steps that countries could have taken, both in the U.S. and other countries, in January, February, to mitigate the poor, non-poor split?
Well, it's again a challenging question. And what I would like to have, but do not have, is cross-country comparisons of inequalities in COVID-19 mortality and excess. I showed you the English figures. There are very similar figures from Scotland, but I'd like to know whether Norway and Denmark and Germany, countries that did better in controlling the pandemic, Taiwan, Japan, countries that did better, do they have narrower inequalities in COVID-19? I think they probably do. So it means that if you control the pandemic well, you don't get such a big excess in the bottom. So let's take bus drivers, which I told you I'm concerned about. bus drivers, of course, are exposed because there's a lot of virus swirling around. And when people get on the bus, they expose the bus driver. If you've got less virus swirling around, the bus drivers are less exposed. So there are two approaches to protecting bus drivers: personal protective equipment, improving the cleanliness of buses and giving them proper protective equipment, and reducing the amount of virus swirling around. So you could potentially reduce inequalities by controlling the pandemic better, because that would benefit everybody, and it would particularly benefit those who are more exposed. In my graph, there was that excess down the bottom, and Dr. Brawley and I were agreed that that excess is related to frontline occupations and overcrowding living conditions at work and at home, and so on. So the first step to reducing inequalities is controlling the pandemic. The second relates to the case I was trying to make, that the causes of inequalities in COVID-19 mortality are similar to the causes of inequalities in health more generally. If you have a country that's taken steps to reduce inequalities in health, it is highly likely that there will be fewer, smaller inequalities in COVID-19 mortality. And then the third thing to say is looking at the effect of lockdown. Take as a non-random example, the United States. Enhanced unemployment insurance made a huge difference to people who lost their jobs. Canceling that at the end of July, is that when it got canceled? At the end of July? Wow. If you want to increase inequalities in health, take $600 a week out of people's pockets. And then that's a great experiment, and see how bad their health gets, how quickly. So there's a great deal that can be done before the pandemic strikes to reduce inequalities in health, in controlling the pandemic overall, and in making sure that the steps the society takes in the face of the pandemic do not by themselves increase inequalities.
Okay. So I have a question from Sandra Durk, a freelancer. Generally, why do we speak in terms of pre-existing conditions when science is just beginning to understand genetics? And maybe as part of that, could you also, what are the definitions of pre-existing conditions that they apply to COVID?
Well, pre-existing conditions are diseases that one has been diagnosed with or one carries: diabetes, hypertension. Some people have coronary artery disease. Any disease, chronic obstructive pulmonary disease we talked about before, they're pre-existing conditions because someone has gotten them and they're now living with them. They're generally chronic diseases that one is living with. And the importance of pre-existing conditions for me as an epidemiologist is they are comorbid diseases that when we put COVID on top of it or put another disease on top of it, complicates both the treatment and worsens the potential for outcome. When I talk about pre-existing conditions, I'm not talking about genetic predisposition toward the disease.
Okay. I think we probably just have time for one or maybe two more questions. I was hoping both of you could address what will happen when a vaccine is ready. How will that be rolled out in both in the U.S. and in other countries, Sir Marot, if you could address that. And is the vaccine infrastructure such that that the poor non-poor divide will still be a big problem, and who gets the vaccine and when?
I think one of the big inequalities, assuming that we do in due course, not when the president says it's likely to happen, but when in due course the trial results are in and we know whether the vaccines are safe and efficacious, there's going to be a huge global inequality in that it'll be available in rich countries before it's available in poorer countries. And that's of deep concern, that the global inequities in access to the vaccine, to vaccines, it should be plural, will be stark. Now, you can see why people living in a rich country want to get the vaccine. But thinking on a global scale, if there is an effective vaccine, we'd like it to be globally available. But think about the logistic problem. We don't yet know if any of the vaccines work. And we'd like tomorrow to be ready in the United States, say, to have 320 million doses of it, or whatever the number is. How do you go from not knowing whether it works to be ready to produce 300x million doses of it? It's a huge logistic issue. And I know in the UK, they've already invested in the capacity to produce the vaccine on a large scale, millions of doses, before they know whether they've got an effective vaccine. The Oxford University AstraZeneca vaccine paused, the trial paused temporarily because there was a side effect. It's now gone on. If it proves to be effective, then there's a huge logistic problem of getting enough doses to vaccinate the whole population. Everything that happens virtually, that's an overstatement, but everything that happens virtually, whether it's a pandemic, whether it's a hurricane, whether it's some external thing, exposes inequalities. And the same's likely to be true when we're talking about a new potential preventive remedy, vaccine. It's likely to be more available to richer, higher income, higher status people earlier. I've already said that's true on a global scale, and it may well be true within the country. And sober-minded people are saying, don't expect the vaccine to solve everything. It won't be 100% effective, even if it is effective. So we're still going to have to take other measures.
I would agree. Dr. Redfield said yesterday, director of the CDC, got some criticism from some politicians for saying that he thought would be in mass for some time, and mass may be more effective than a vaccine. I'd point out that the National Academy of Medicine has been asked to come up with some type of plan as to who should get the vaccine first. But as Sir Michael said, middle class or wealthier people seem always to come out on top in all of these things, even when it comes to vaccine. The other thing that hasn't been talked about a lot is the vaccines that are currently being tested, if they were, are going to require transportation at very low temperatures. And the logistics of transportation and the logistics of distribution become really a big problem, as does the fact that most of these vaccines, if they work, are going to require administration at day 1 and day 30. So 2 administrations is more than twice as complicated than just 1 administration.
Okay. And this will be our final question. It's from Camelot Todd of Spectrum News Buffalo and Report for America. What are the long-term implications of COVID on people's mental and behavioral health? Is it likely there will be more people that live in poverty who are diagnosed with depression or substance use because of this? Dr. Brierley, can you maybe take that one?
I'm speculating. I think yes. As I said earlier, I'm very, very concerned about PTSD, post-traumatic stress disorder, being a common problem in people, both because of the COVID COVID epidemic or pandemic as a whole, and because of them having experienced the illnesses caused by the disease. So I'm very concerned about long-term mental health issues, and that would include depression.
And there, exactly, I'm with Dr. Brawley, exactly as he said. There's concern about long COVID, about the effects lasting longer. People don't die, they get treated, they survive the initial infection, but the effects last longer. I don't know any data about the inequalities in long COVID as yet. But for the reasons Dr. Brawley said earlier about pre-existing conditions, and the poorer you are, the more likely you are to be vulnerable to the effects of the infection and the disease, it's predictable that there will be inequalities in the long-term effects of COVID-19.